Welcome back to Mastering Medical. This is part 1 of our Hematology Rapid Review, the anemias. We move from macrocytic to microcytic to hemolytic, and for each pair we lock in the one finding that tells them apart. Let's get into it. We start macrocytic. Both vitamin B12 and folate deficiency cause a megaloblastic anemia with hypersegmented neutrophils, and both raise homocysteine. So which lab actually separates them? Homocysteine rises in both, so it cannot separate them. The separator is methylmalonic acid. B12 deficiency raises methylmalonic acid and damages the dorsal columns and corticospinal tracts, giving subacute combined degeneration, lost vibration and proprioception, and an ataxic gait. Classic causes are pernicious anemia, a vegan diet, and terminal ileal disease. Folate deficiency keeps methylmalonic acid normal and has no neurologic findings. Think poor intake, pregnancy, or drugs like methotrexate. And always replace B12 before folate, because giving folate alone corrects the anemia while the neuropathy keeps progressing. Now microcytic. Both iron deficiency and anemia of chronic disease drop the serum iron, so serum iron alone is a trap. You have to read ferritin and the total iron binding capacity together. In iron deficiency, the stores are empty, so ferritin is low. The total iron binding capacity is high, transferrin saturation is very low, and the red cell distribution width rises. In anemia of chronic disease, the stores are locked, not empty. Inflammation raises interleukin 6, which raises hepcidin, and hepcidin traps iron inside macrophages and blocks absorption from the gut. So ferritin is normal or high, and the total iron binding capacity is low, with a chronic driver like infection, cancer, kidney disease, or autoimmune disease. Low ferritin with a high binding capacity is empty stores. High ferritin with a low binding capacity is locked stores. Still microcytic, but now a three-way split. Iron deficiency, lead poisoning, and sideroblastic anemia all run small. The question is whether iron is absent, poisoned, or trapped. Iron deficiency is iron that is simply missing. Low ferritin, a high binding capacity, a high red cell distribution width, and clues like pica and spoon nails. Lead poisoning is a heme synthesis problem. Lead blocks two enzymes, so you get coarse basophilic stippling on the smear, an elevated blood lead level, and clinically wrist drop and abdominal colic in adults, or learning problems in children. Sideroblastic anemia traps iron in the mitochondria, so the marrow shows ring sideroblasts on Prussian blue stain, and iron and ferritin are actually high, so absent iron is iron deficiency, stippling with a high lead level is lead, and ring sideroblasts with high iron is sideroblastic, which you treat with vitamin B6 in the inherited form. One more microcytic pair inherited with normal iron. Thalassemia is a globin production problem. Alpha versus beta comes down to the type of defect and the electrophoresis. Alpha thalassemia comes from deletions of alpha globin genes on chromosome 16, and severity tracks how many genes are lost. In alpha trait, the electrophoresis is often completely normal, which is the classic trap. Lose 3 genes and you get hemoglobin H, lose all 4 and you get hydrops fetalis. Beta thalassemia comes from point mutations on chromosome 11. In beta minor, the hemoglobin A2 is elevated. In beta major, the child is healthy at birth but crashes after a few months as fetal hemoglobin falls, with target cells and massive marrow expansion. So microcytosis with normal iron and a normal electrophoresis is alpha trait, while a high hemoglobin A2 is beta trait. Now the hemolytic anemias. First, inherited red cell defects. Is the problem the membrane or an enzyme inside the cell? Membrane disease means hereditary spherocytosis. A defective membrane skeleton makes spherocytes that the spleen eats, giving extravascular hemolysis, splenomegaly, pigment gallstones, a high mean cell hemoglobin concentration, a negative Coombs test, and increased osmotic fragility. Enzyme disease usually means G6PD deficiency, where an oxidant stress, like an infection, fava beans, or drugs such as dapsone and primaquine, triggers episodic hemolysis with bite cells and Heinz bodies. Pyruvate kinase deficiency is the other enzyme defect, causing chronic hemolysis from low ATP. So spherocytes with increased osmotic fragility is membrane, while bite cells and Heinz bodies after an oxidant is G6PD. Spherocytes show up in two very different diseases. When you see them, ask, are these inherited membrane spherocytes or red cells coated by antibody? One test settles it. The deciding test is the direct Coombs. Hereditary spherocytosis is inherited and antibody negative, so the Coombs is negative. You also see a family history, a high mean cell hemoglobin concentration, and increased osmotic fragility. Autoimmune hemolytic anemia is acquired and antibody mediated, so the direct Coombs is positive, often from lupus, CLL, drugs, or infection. Remember the split. Warm autoimmune disease is immunoglobulin G, cold agglutinin disease is immunoglobulin M with complement. So the same spherocytes, but a negative Coombs with a family history is hereditary spherocytosis, and a positive Coombs is autoimmune hemolytic anemia. If the Coombs is positive, you're dealing with autoimmune hemolytic anemia, and now the antibody class splits it. Warm or cold? Warm autoimmune hemolytic anemia is an immunoglobulin G problem. The antibody coats red cells at body temperature, the spleen removes them, and the direct Coombs is positive for immunoglobulin G. Triggers are lupus, chronic lymphocytic leukemia, and drugs. Cold agglutinin disease is an immunoglobulin M problem. Immunoglobulin M fixes complement and clumps red cells in the cold, so patients get painful, bluish fingers and toes, and the direct Coombs is positive for complement, C3. Classic triggers are mycoplasma pneumonia and Epstein-Barr mononucleosis. So immunoglobulin G is warm, immunoglobulin M is cold. Last anemia pair, you find hemoglobin S on electrophoresis. But not every hemoglobin S patient has full sickle cell disease. Severity depends on what is paired with it. Homozygous disease, hemoglobin SS, has two sickle genes and no normal adult hemoglobin, so it is severe. Vaso-occlusive crises, dactylitis in infants, autosplenectomy with Howell-Jolly bodies, acute chest syndrome, and a special risk of Salmonella osteomyelitis. Hemoglobin SC disease pairs one sickle gene with a hemoglobin C gene and is generally milder, but watch for retinopathy and a vascular necrosis. Sickle trait has more normal adult hemoglobin than sickle hemoglobin and is usually asymptomatic, though it can cause painless hematuria. So no normal adult hemoglobin means disease. Present normal hemoglobin means trait, and a hemoglobin C partner means hemoglobin SC disease. Let's lock it in. B12 versus folate. High methylmalonic acid with neuroscience is B12. Normal methylmalonic acid is folate. Iron deficiency versus anemia of chronic disease. Low ferritin with a high binding capacity versus high ferritin with a low binding capacity. Iron deficiency versus lead and sideroblastic. Basophilic stippling with a high lead level is lead. Ring sideroblasts with high iron is sideroblastic. Alpha versus beta thalassemia. A normal electrophoresis is alpha trait, a high hemoglobin A2 is beta. Membrane versus enzyme hemolysis. Increased osmotic fragility is hereditary spherocytosis. Bite cells and Heinz bodies after an oxidant is G6PD. Spherocytes with a negative Coombs, and a family history is hereditary spherocytosis. A positive Coombs is autoimmune hemolytic anemia. Warm is immunoglobulin G, cold agglutinin disease is immunoglobulin M with complement. And for sickle disorders, no normal adult hemoglobin means disease. Present normal hemoglobin means trait. That is part 1. Part 2 covers bleeding and clotting. See you there.